All right, and should be good to go.
Well, thank you, Johnny. Oh, good morning, everyone. My name is Jorge Gonzalez. I'm the program manager for the Medical Psilocybin program. Welcome and good morning. We're here with Ian Dunn, who is the chair of the Dosage Administration and Clinical Practice Committee, but also the chair of the Medical Psilocybin Advisory Board. So I just put a message in our chat. Please remember that this meeting is being recorded and to keep language appropriate as the recordings are made public on the website. We have the cameras off, and that is because same thing with language. In case there is something that may be inappropriate for the background, we have turned off all cameras, but we will open the mics for folks when you are ready to speak. And with that, we will have Ian start the meeting. Ian?
Good morning, everyone. Welcome to the Dosage Administration and Clinical Practice Committee. Today, we're going to be going over preparation and administration sessions, bringing together what we had discussed last meeting. We distinguished the different clinical roles, and this would be the application of those different clinical roles. If Jorge would like to bring up the preparation sessions, while we would begin with introductions. If you would like to participate in today's meeting, just a brief statement about your name, who you are, any affiliations. But if you would like to participate, please raise your hand at this time.
All right, and first up, we've got Lori Golzar. And Lori, I have enabled your mic.
Thank you. Hi, good morning. Thanks for being here. I'm Lori. I live in Farmington, New Mexico. I'm a FNP and a PMHNP, and I work full-time for Senecor Foundation, a substance use disorder facility, and I also have a psychiatric clinic there where I see outpatients as well in the community. So yeah, thank you so much for being here. Appreciate it. We are hopeful to present this to our organization in Texas so that we can potentially provide psilocybin therapy at our facility here in Farmington. This is just a thought, and we are bringing it forward to them. So I'm hopeful to get as much information as I can. Appreciate it.
Awesome, thanks. And let's see, next we've got Chris Peskusky, and your mic is enabled.
Good morning, everybody. Chris Peskusky, Advisory Board member. Just happy to be here.
Awesome, thanks, Chris. And next, we've got Don Moser, and your mic is enabled.
Hi, Don Moser. I live in Las Vegas, New Mexico, and I'm here to learn as much as possible. Thank you so much for all your work.
Awesome, thanks, Don. And next we've got Cassandra Veaton. Let's see, and your mic is enabled. Oh, and sorry, to unmute, we'll still want to go.
Got it. Okay.
Yeah, there you go.
Yeah, great. I'm Cassandra Veaton. I'm a psychologist. I live half-time in Lamy, New Mexico, and half-time in San Diego. And I'm a co-founder and clinical psychology director at the Center for Psychedelic Research at UC San Diego.
Awesome, thank you. And next we've got Brenda Burgard, and I have enabled your mic.
Good morning, everyone. I'm Brenda Burgard. I am chair for training and education for the DOH here for psilocybin. Thank you, and I hope we have a great meeting this morning.
Awesome, thanks, Brenda. And next we've got Jessica Eden. And Jessica, I've enabled your mic.
Hello, my name is Jessica Eden. I am a licensed clinical social worker in New Mexico and Colorado, and also a licensed clinical facilitator in Colorado. And so I've been working with psychedelics and psilocybin specifically for about the last 4 years. And so I'm just here to participate and learn. Thank you.
Awesome, thanks, Jessica. And looks like that was the last hand I saw up. So we'll send it back to you, Ian.
Perfect. So in the last meeting, we had talked about the differentiation between psychological preparation and administrative preparation. So just to kind of get into the guidance of those differences, this document would kind of help to specialize which one would be doing which. As a reminder, a psychedelic therapist is the more holistic model, whereas a facilitator is generally the person that is with them during administration. Generally doesn't have to be separately credentialed outside of the Department of Health, whereas the psychedelic therapist is generally already a licensed healthcare provider. So let's get into the psychological preparation. So the psychedelic therapist must be involved in the psychological preparation process to establish the clinical foundation for treatment. So they establish the timing. This phase must occur first to allow the therapist to determine medical appropriateness and approve or defer participation based on safety. Clinical assessment, the therapist conducts a comprehensive biopsychosocial assessment and reviews medical, including medication interactions and contraindications, mental health and substance abuse history. Intention setting and objectives. The therapist facilitates the discussion of patient goals, intentions, and expectations for the session to establish a psychological framework for the experience. Orientation to set. The therapist addresses the patient's physical, emotional, and psychological readiness, helping them navigate set factors and potential psychological changes. Clinical safety planning. This is where they would evaluate risk for adverse responses, create a formal safety plan, and perform an assessment of the patient support system. In terms of cultural and spiritual alignment, we would use trauma-informed and culturally competent communication. The therapist ensures alignment regarding any ceremonial, cultural, or spiritual elements that may be present. Dosing and tiering. During this phase, the therapist assigns the clinical support tier and establishes dosing parameters or considerations. If a patient is determined to be clinically inappropriate, the therapist is responsible for referring them to a primary care provider or other appropriate treatment avenue. So that would be kind of the psychological preparation, what we're wanting them to do beforehand. In terms of administrative preparation, this would be primarily done by the facilitator in order to ensure, the proper personality fit when you are going to be with this person. Maybe not next to them 24/7, but just they're going to be the presence to ground you if you do have an adverse reaction. So we want to have them obtain and document informed consent during the session. This will happen after the psychological preparation. This session is a primary opportunity for the patient and facilitator to ensure their rapport is good enough to fit the patient goals. This phase includes establishing boundaries such as touch preferences, providing written disclosures, and orienting the patient to non-clinical scope of the facilitator. The facilitator orients the patient to the physical environment where the session will occur. This includes reviewing environmental conditions, the lighting, the temperature, the sound, explaining privacy measures, and ensuring the patient is comfortable with the facility layout. The facilitator is responsible for knowing how to escalate medical or psychological concerns to the psychedelic therapist or emergency services, depending on what the specific adverse event is. And this should be part of their orientation, and they should provide the materials for the patient self-administration in accordance with the therapist's direction. Some combined timing and compliance standards. This is still pretty up in the air. Patients shall complete at least 2 preparation sessions totaling no less than 3 hours prior to administration. At least 1 session must be dedicated to psychological preparation, at least 1 session to administrative preparation. Where feasible, at least 1 hour of total preparation time shall be conducted in person. Psychological preparation must be completed and clinical appropriateness determined before the final administrative preparation session is concluded. And all activities, including clinical screening results from the therapist and informed consent from the facilitator, must be documented in the patient record. So now I'll open to any discussion, questions, comments, concerns on the preparation sessions.
All right, and Lori, I see your hand up. You can unmute when you're ready.
Thank you. Hi, just a couple questions. One is, you refer to the therapist, but say it has to be a a licensed clinical role. So is this like a provider, like either a doctor of psychology or a PMHNP or psychiatrist in this? I'm just want to make sure I understand, or could this be any licensed therapist that could be considered therapist, psychological therapist, please? Thank you.
Generally, it would be a
Psychedelic therapist.
therapist with additional training on specific assessment and general psychedelic assessment. This committee in the past has found that most medical institutions don't teach about psilocybin use, so we would have to provide that education ourselves anyway. And that's why we had opened it up originally to social workers or clinical counselors or PhDs who um, may have who are going to have additional training with the program.
Okay, so they don't have to have a medical background specifically. I mean, I understand we all have to go through the training anyhow, like Dr. Fatima or Fatimi, I don't remember how to say it. I know she has like a conscious physician program to teach providers. So they don't have to be medical providers to be a psychedelic therapist?
At this time, no.
Okay, thank you.
All right, and Chris?
You know, I'm curious what happened to the document we were working off of last time.
This was the new document that's sent out. The document we were working on last time was just the clinical roles.
We had a preparation document that we were working from.
Yeah, so that one was based on before we had done the clinical roles, and at the last meeting, I had sent out an additional copy of a new preparation based on the updated definitions of the roles. Because the past one had the facilitator doing everything, and in the last meeting, we had discussed the difference between psychological and administrative preparation.
All right. I think it's a little bit frustrating that we have new documents every time. Like it kind of dishonors the process that we were working on all of that stuff, and now we're starting new.
Right, but the previous document didn't bring up the concerns of the separation of psychological and administrative preparation, which was brought up. And then at the end of the last meeting, I had let people know, well, these definitions no longer apply. So we're going to go ahead and generate a new one. I had it sent out last week to be reviewed, and then now we're here.
So I think we also talked about, based on the clinical tier that people fall into, that a lot of this work could be done by the facilitator if it's not complex cases. I think this is very restrictive. And is there any, I mean, the psychological preparation, administrative preparation, I get the difference of that, but I don't know that that's like necessarily has to be a split roles like this. And the people that are sitting should kind of be involved in this whole process, especially the cultural spiritual alignment section. I think if we're going to split this up like this, it needs to be in the facilitator part.
All right, I'm fine with that. The cultural and spiritual alignment.
Could I talk again, please?
Yeah.
So as far as like the clinical assessment part goes, doesn't that need to be by a medical provider of some capacity? We had, in the previous meeting, I know we had discussed that they will be meeting with like a psychiatric provider or someone like that prior to determining that this would be a good therapy for them. So that sounds like that's the psychological preparation portion. And I don't know that I feel very confident that even a trained therapist would be able to really determine if the medication interactions and history and physical assessment would be conducive to a psilocybin therapy. You know what I mean? Thank
You
you.
don't think we could teach on a singular drug's medication interactions and
I
a
think
singular drug's contraindications
I
and a
think we
singular drug's biological histories that would be contraindications?
I'm not saying I don't think it could be taught. I'm saying that the training that we go through as medical providers, years of physical assessments and history taking and psychiatric assessments, a lot of people might present to the clinic as, no, I've never had this bipolar disorder or whatever it is. And it's, just by somebody saying so doesn't make it true. That's why I feel that it would be more safe. I mean, are they going to be, you know, do they really know the parameters of a safe blood pressure and things like that? I just, it seems like a lot to place in the hands of a therapist, in my opinion.
I disagree. Most assessment is taught within the first 2 semesters of nursing school. Um, in terms of those critical ranges, in terms of being able to beginning to assess medication interactions, contraindications, all of that begins second semester of nursing school. So I think it would be feasible to say we can teach this for just one drug.
Yeah, yes, but you were accepted into nursing school because you understand and comprehend like complex, physical systems. I'm not saying anything negative about therapists. Trust me, I absolutely require them. I just am saying that the mindset is not a medical background mindset. It's different. So I don't know that I don't know very many who would really be very good at that. Sorry about my dog.
And then I do see some other hands. So Chris?
Or I think we have Cassandra first.
Cassandra, sorry, I just saw the C.
Oh no, you're good.
No problem. So is there an assumption, as Ruben said, Dr. Sutter said in the chat, that there has been a medical clearance, or are we proposing that there does not need to be a physician clearance prior to getting treatment, even online or,
Like, in what regard?
Okay,
this,
so let's just say somebody says, I'm interested in doing psilocybin treatment. Are they required to clear it with their physician or a physician prior to starting this whole preparation process?
let me get Dominic to clarify.
Yeah, and he did drop something in the chat.
Dominic
morning.
must be certified. Yeah, exactly.
Good morning, everybody. Yeah, just to clarify, what we're talking about on this preparation phase is all of that medical certification aspect. So the patient has already gone through a clinical medical evaluation that they have one of the qualifying conditions. That has already occurred. They've been referred into the program. And then these stages are with the therapy level. Now, in the best world situation, and what should be happening, regardless of anything else, is all of the members of the care team. So that should be the medical provider, so the clinician, the therapist, the facilitators, etc., should really be working together, consulting with each other to ensure that all of this is happening. So this stage where we're looking as far as for preparation really is the patient has already gotten cleared from the medical. They're going through their preparation, so the therapeutic, but that is still going to include some of that medical interactions and some of those other information, which some of that should come from the clinical aspect. And then moving forward with the administrative as far as for the facilitator, which is part of what in the last meeting had been requested, the therapeutic and the administrative be separated out. So that's just really what this is going through. And Dr. Sutter, I completely agree, but remember, these are guidelines. These are not regulations. So this is what the guiding document as far as how providers should move forward with it. And definitely agree that there should be that clinical documentation. But again, these are not requirements. These are guidance for your best practices, which
Yeah,
we
so I
don't
think
put into regulations. So
I think what a couple of us, can you hear me?
yes.
I think what a couple of us are saying on the call is that the way it's framed right now is that a psychedelic therapist would be responsible for assessing medication interactions and contraindications, and that probably should be done by a physician.
Mhm.
That's all. So
Sure. And I think it's just the language utilized is a lot of that would happen beforehand, but also during that preparation, there should be the ongoing discussion of that. So for example, a great example.
no, I mean, I think we understand what you're saying. I think we're just suggesting that perhaps this item would say, reviewing the physician's, yeah, that an LCSW would not be able to medically clear someone for potential serotonin syndrome, or, so maybe in the medical history bullet point, there needs to be some slight change in, yeah, I think maybe what you just did, review, is better than than do it. Yeah.
Mhm.
And then I did see in the chat, the review of meds is outside of a scope of practice. And I do want to clarify that we are providing areas where this would be within their scope of practice. This is not an existing function for anyone to dispense psilocybin outside of controlled research. So outside of the scope of practice is not really a concern because we're going to have to provide them with additional education anyway on psilocybin. Psilocybin education is broadly not taught in medical schools or nursing schools. So we can review the medical history and those medication interactions, which this committee has, or patient qualification and safety has provided lists of on these topics to try to get as much access as possible. There are a bunch of resources in today's world that can even help to expedite and to allow more participation, but I do agree that there should be clinical oversight, but here it's just supposed to be, they're supposed to look at their history to make sure that nothing was missed.
Yeah, I think the way it's framed now is better than the way it was framed before. I think it's good. I also just had a question about these committee meetings. So are some people allowed to chat and turn on their camera, and some people are not allowed to chat and turn on camera?
So the only people we have on camera generally is going to be the committee chair and occasionally some DOH folks. We also generally want to, as much as we can, keep it so that we're going in order of whoever raises their hand. And then anybody can put anything in the chat as well.
Yeah, For some reason, I don't seem to be able to chat, but I guess I'll figure that out
Gotcha.
later.
Yeah, there are unfortunately occasionally for some people just yeah, there have been folks who haven't been able to put stuff in the chat, unfortunately. Sometimes there's, yeah, occasionally there will be a thing that says like some people are outside of the org. It's possible they have message related policies that will not allow them to use the chat. So I do see that notification right now. So that's unfortunately not something we can change on our end. But I am going to go to Chris next.
Yeah. I guess first, I'd like to make a request that people that didn't introduce themselves, please introduce themselves before they're talking. I've seen a lot of new faces in here suddenly and no context as to who you all are. And beyond that, like, I think we've already had this discussion several times, but I don't think, the safety profile of psilocybin is very good. And I do not think MDs are the proper clinician to do that evaluation. I don't think that's necessary. I think that we can keep the evaluation done with people that have diagnostic authority. And again, the safety profile of psilocybin is very good, and we can easily train these people to do that work. And then I had something else, but hopefully it'll come back to me. I got lost in the conversation. Thank you.
All right, and Greg Evans, I've enabled your mic and you can speak when ready.
Good morning, everybody. My name is Gregory Evans. I'm an independent home mycologist and researcher. Couple things, trying to gather all of my thoughts because there's lots going on here. And I want to try to speak from a place of like bridging modalities, bridging gaps. I think one of the things that I wanted to kind of catch that Dr. Zurlo mentioned is that imagine we're in a pipeline and the pipeline goes through a singular hole and then it spreads out and has options. That singular entry point to the program has the qualifying condition, the contraindications, medical readiness, all of that assessment is complete. And that allows for a broader range of therapy models that are like participant centric. So if a person enters into the program with, and I want to pause myself here and say, this is how I see it, and I see it working best. And none of what I am saying should be said as like codified process, because we are in the process of doing that today. If there is a participant that enters the program with a doctor that is also a different, like has different types of therapy in their practice, that has the ability to qualify them for the program, which involves all the contraindications. And I will say, if we're bringing up serotonin syndrome, we need to really go back and understand what the drugs that we're dealing with are. We are not dealing with ketamine. We are not dealing with MDMA. We are not dealing with any compound that is known to commonly by itself under like proper diagnostic protocols trigger serotonin syndrome. The research is out there. We're going to get more. We are in the early stages of understanding this chemical in general, but we're not at the beginning. So if that person wants to stay with that practitioner all the way through as their facilitator and their integration coach and their preparation team, that with that single person, that's a possibility. There are possibilities where a person can qualify and then reach out to their culturally appropriate preparation, like the person that they want to guide them through preparation, sit with them in medicine. And honey, I just parked to have a little chat. We're going to go back to your school in just a minute. So I just think it's really important to understand that there's nothing in the program that is taking away the medical safety mechanism. What I think is happening is that there is a mechanism that is triggered and authorized. And once you're in this container, there are multiple pathways to realize the process of the therapy. It's like you get in, like, it's not, the program is not for administering medical psilocybin. It is a container of therapy that extends across months. So if somebody wants to select a different team or select a broad range of people to be a part of that team, those teams need to communicate together. But I hope, I don't know, I'm gonna land it there, but I hope that makes some sense.
Thank you. And I do appreciate everyone's input. I do want to remind everyone this is a settled issue. This committee has already voted and adopted saying that therapists are okay. So we can't, I mean, we could try to go back, but it's not worth our time to go and rehash every single argument that's ever been had. So in regards to preparation, are there any other just questions, comments, concerns, or changes? I did update that medical history. Questions, comments, concerns. I will let Johnny go back to calling the roll.
Cool. All right. Lori, see your hand up.
Yeah, I know we have limited time. I'm sorry to take up the time, but can I please clarify a couple things real quick? One is, remember it was talked about that there would be, and I know this is a moot point at this time with the therapist thing, and I'm totally on board with the therapist providing that role, by the way. I just want to make sure that we are safe as far as a medical provider reviewing that person's history and physical assessment and all that stuff. As far as like during the administration, though, I thought we had mentioned that there would be some kind of medical provider on site or available during the time of administration, like on call for them. I thought they had to be on site. Maybe I was dreaming about this, but I thought we had talked about that. I have that question, and then I have one more question, and then I'll be quiet. I know you guys, and this is not about this specifically, but had been talking with Medicare and Medicaid about reimbursement. And I wondered if there was any, I'm just trying to bring this forward to our executive team in Texas, and I need that piece of information. Do we think that insurances are going to be covering this? Does anyone have any insight into that? I would love that information today. Thank you so much.
So I think, yeah, Ian can probably speak to that first question, and then Dominic can speak to the second, I think, a bit.
Yeah, so we had that if you had an inability to access emergency services and you could find someone, you could have someone to administer emergency medicine on site. But there was no requirement that they would have to if they have appropriate access to emergency services that worked in that regard.
Okay, thank you.
And then this is Dominic in regard to the question as far as insurance and or Medicaid. We are actually working with HCA to see what aspects could potentially be covered for example, the preparation, the therapeutic preparation, the integrative therapy afterwards. However, it does appear as though administration itself, of course, which this is not surprising, I think, to any of us, because it is Schedule 1, would not be covered. However, again, that therapeutic sessions, it looks like it will be, but there is no definitive answer yet. And I don't know that we're going to have that anytime in the next month or two, for example. That may take longer before we have those answers. However, we are continuing to work with regard to that.
Great, thank you.
And actually, I will note, Jessica posted in the chat that if it's an unlicensed person as a facilitator, that is correct, that they would not be able to bill to insurance. And it is part of why we specify in a lot of places the licensing aspect of this, because it's only going to be those licensed individuals who are going to be able to bill. Individuals who do not have licensure are not going to be able to bill with regard to this. So thank you, Jessica, for pointing that out. I appreciate the assist.
All right, and oh, let's see. I saw Ruben Sutter's hand up. And okay, yeah, your mic is enabled if you want to unmute.
Okay, unmuted. Yeah, it's Ruben Sutter. I'm an addiction psychiatrist. I own Sage Neuroscience Center here in Albuquerque. Very much in agreement with the safety of psilocybin and these drugs. Given that we're putting this in the medical context of the medical clearance, we do have to sort of honor those pathways. And I know we've talked about that in terms of ensuring medical clearance. My concern in terms of therapists being licensed providers needing malpractice coverage, we want to be certain that they're not being asked to do anything that is out of their scope of practice. And so in terms of reviewing medical history or anything, that's certainly valid, that if they have the documentation from a medical provider, mid-level or otherwise, which also is perfectly reasonable, that they're just verifying this with the client rather than doing the assessment. And if there's anything different, I might suggest that then they refer back to the medical provider. Largely, one, it's scope of practice, and second, we're going to have malpractice insurance, and there's going to be risk of liability here, and I don't want somebody to be at risk of doing something that is outside their scope that would expose them. That's all.
Thank you. And I do want to point that out. Yes, if a patient is determined to be clinically inappropriate, which means one of their conditions matches on their list of diagnoses matches to a list provided, then the therapist is responsible for referring them back to their primary care provider or other appropriate treatment avenue. So yes, I completely agree. Thank you.
All right. Next we've got Catherine Warnock. And Catherine, I have enabled your mic.
Hello and good morning. I'd like to kind of bring us back to topic, if that's okay. I feel like we've been talking about a lot of things that have already been resolved or are outside of the scope. I'd like to just kind of mention that I think that there's two things that are missing from this list. And by the way, I'm Catherine Warnock. I am a psychedelic therapist in Las Cruces, New Mexico. Been doing this work for about 5 years. I think we need to add something about matrix, making sure that the people have safety in where they're landing after the experience. So set and setting are really critical. We all know that, but I think matrix gets missed a lot. And matrix is like, are we sending them back into a system that is healthy and that's going to support this type of a treatment? So for example, if I'm working with a client who is in a domestic abuse situation, the last thing I want to do is send them back into that with their mind being open and they're very vulnerable. Even if it's like the day after or 2 days after, there needs to be like plans around where are they going after the experience. So I think that's really important. And then also, are we going to provide any education about the process, meaning what psilocybin does in the brain, what, the neuroplasticity, are we going to include any information about what, you know, what they should, I mean, yeah, I see that you have expectations in there, which is really good, but just some education about what it is, what it does, what it's for. You know, just want to mention that as well. Thank you. And thank you, board, for all the time and effort you put into this. This is a thankless, paidless job. So I just want you all to know I appreciate all of you.
Awesome. Thanks, Catherine. And while he's updating that, we'll go to Brenda.
Hello, everyone. I'm Brenda Burgard. I'm Chair for Education and Training for Psilocybin. I just want to address that. I think with any type of training, you're going to have a preparation for the clinician and the patient. So when the patient is there in front of you, you're explaining to them and you're having a handout sheet about what to expect before, during, and after preparation. The preparation is vitally important as a clinician to give that information to the patient or client that you're working with, because they are the ones that are going to decide whether or not to continue with this program. There should be an opt-out segment in this too, because the patient should be able to opt out at any time. But preparation and education for the client is vitally important. So I think whenever we have a patient or a client come to us, the first things we do is we prepare them for therapy in general. And this should be really nicely wrapped up in a nice little package here for information. I think that when we do that, the client or patient will feel more comfortable with working with this medicine. And another thing I wanted to preface too is that as a therapist myself, I often ask what types of medications that they're on, how long they've been on it, how much they're taking, to see if there is any contraindications of the medication they're presently taking. And if I see anything, I refer them back to their medical provider to just, check to make sure that this is appropriate medication. So I think when we really get into the education and training of all of this, this will be part of the training for the clinician to prepare the client or patient.
Awesome. Thanks, Brenda. And yeah, whenever you're ready.
Perfect. And then, so to kind of sum up the two last points I heard, so the general education on the who, what, why, and how of psilocybin and potential adverse effects, it should be provided in an easy read, digestible format for patients. And then the matrix, but can you provide words? Because I don't know why
for matrix, I would say something like assessment of suitable matrix, just making sure that we that it's being looked at, and that if accommodations need to be made, they have to stay with the family member for a week or somebody that's safe, or it's basically just assessing and then making accommodations for a suitable and healthy release into an appropriate matrix. I know that's very wordy, but you just want to make sure that the environment and the people that they are going to be on board. Like, the worst thing you want is somebody being released and everyone's going to make fun of them because they had this treatment. It's not going to, it's not going to provide positive outcomes. We're trying to do everything for positive outcomes. I think you did a good job there, Ian.
Thank you, but I stole it from Ruben Sutter in
Great.
chat.
Great. Thanks, Ruben.
All right. Perfect. And then we wanted both of those to be under the psychological preparation.
I think so, yes.
Okay. Perfect. Alrighty. Any other questions, comments, concerns?
See, I see Jessica Eden's hand up, and you can unmute when you're ready.
Okay. Thanks. And then I just wanted to mention that like when I mentioned aftercare, like that's not necessarily integration. That's like aftercare in that night of the day after, like emergency sort of like if they're going to be able to reach out to the facilitator or the therapist or a fireside chat, something like that if they need something right there before their integration session is kind of how I look at that. This a different thing, a different comment or question that I have is I noticed that you took out therapist conducting the comprehensive biopsychosocial assessment and reviews from that medical history section. And I'm just wasn't sure where that went because I think that that is something that the therapist should be doing, and that could be shared even with the facilitator, because that's a lot of history that's taken, and we would look at that for any sort of red flags, even in the history, that we would want to address. And then let me know if you need me to stop. My other piece would be, oh shoot, I'm sorry, I forgot my train of thought there. I'll have to come back to it.
No worries, it happens to the best of us. It's Cinco de Mayo, my brain already on margarita time.
Oh, this is what it was. I wonder if the psychedelic therapist during the process of psychological preparation should then be determining and making a recommendation for the appropriate number of preparation sessions based on their assessment and what they're finding. So like with the minimum of these two, but then they can make a recommendation that there should be maybe 3 or 4 of them or, whatever they're needing.
So I do like that determines the number of requisite preparation sessions to administration. Is that a good phrasing for everyone?
Right, I see Chris's hand up. Chris, you can unmute when you're ready.
I wonder if maybe determines readiness might be more appropriate rather than like the way this reads, it makes you sound like, well, based on your history, I think you should have to do 5 preparation sessions, but I don't think that's realistic. I think, as they're working together, maybe readiness is a better measure.
All right. And then, cool. Alrighty, any other questions, comments, or concerns? All right, then we can go ahead and vote on this now. All those in favor of adopting the preparation sessions document as proposed, please raise your hand at this time.
Ian, I don't think we spent a lot of time on the facilitator section.
Does anyone have any questions, comments, or concerns about the facilitator session? You can go ahead and put your hands down at this time.
All right, Catherine, I see your hand up. You can unmute.
Yeah, I'm actually thinking the cultural and spiritual alignment needs to be in both. Like, I'm just thinking it needs to be all the way through. I don't know.
Cool. I went ahead and added it to psychological preparation.
Okay, excuse me. And before we go to Chris, let's see, I just see Ruben had a couple or a question in there. Will there be a minimum expectation for observation?
We will have to determine that at administration.
All right, and we'll go to Chris.
I think I brought this up before, but some things have kind of changed since then. It is 60 days before administration. I'm not sure that's really appropriate for somebody. I would think maybe no more than 30 days, and they're probably meeting with their psychedelic therapist more frequently or before they're meeting with their facilitator. I mean, hopefully all this is happening in conjunction, but I think it might want to be closer to administration than 60 days.
I believe it's based on Colorado's was 60 days. I would have to fact check myself, but it was either Colorado or Oregon that had the baseline, and we just moved there. We can change it if you would like. But 30 days seems a little bit difficult if we are, sending them back to be tapered off of medication, and then we need more administration sessions because they weren't completed within the last period. And it was a thing about boundaries, but I would be okay with changing it to 30 if that's what the committee agrees with.
Let's see, and I see Gregory Evans' hand up, and you can unmute when you're ready.
Thank you. I would second that 30 days, simply because we're not constraining people from having a longer period. We're constraining like the minimum easiest path. Also, I think having wow, bugs. We're having I'm sorry, totally lost my train of thought. If we're going to consider having multiple sessions, those secondary sessions shouldn't be behold to the primary sessions constraints. So if somebody is received like their primary session, and then their team themselves decide that they should go back in. I don't think that they should have to wait 30 or 60 days. I think it should be per the determining clinician team.
Cool. I went ahead and updated it to 30 days. And then Dominic?
Yeah, good morning, Ian. It just seems, since we only have a couple of minutes left in this meeting and there still seem to be some questions, what I would recommend at this point is to go ahead and let people sit with this until the next meeting before doing a vote, just to ensure that they have enough time to review it and see if they have additional questions or, you know, ideas for some of the changes, especially with regard to the facilitator, since we just started reviewing that portion.
All right. That sounds good. I am very busy for the next 2 weeks. Does Wednesday the 27th work for the department and everyone in the committee?
Let's take a look. For us, Wednesday the 27th should be good. Do we want to do 9 to 11 for that one, just in case?
Sure.
Okay, cool.
Alrighty, since we are out of time today, I do appreciate everyone for taking the time to be here and share your thoughts with us. I appreciate everyone's opinions, and just, you know, taking time out of your day. It's something you don't have to do and something that's so easy to not do. So I do thank you for being here. But have a great rest of your week. Enjoy your Cinco de Mayo and be safe, everyone.
Thank you for your time.